Sorry, I was just.
Excellent. And so we're talking about the factors of pediatric sleep health and what factors into really ultimately sleep insomnia in these kids. So the mesosystem, the microsystem, and their mesosystem, their family, their social household stress has been noted to be a big one. Chaos, right? So like if there's no routines, there's no regularity, that's tough because your life is going to be a long visit. Because you want to just introduce regularity, maybe even for the first time. Children with bedtime routines more likely to have less sleep problems. So for instance, and some other factors, and it's bi-directional. So if this child is ill, it becomes a parental stress issue and vice versa. So these things are bi-directional, and they may have multiple households, and they sleep at different households, and those things come into play. And then there's the microsystem, neighborhood, broader culture, as state levels will start. We had the COVID situation, right? And so what's happening on the larger norm that may cause insomnia in some people. All right. And then we want to also hit on when to refer. So when is it, and this is meant sort of for other people, not us necessarily as sleep specialists, but when do we want to also, get a phone with polysom if there's other risk factors, especially sleep maintenance problems. We're looking for sleep apnea. If there's restlessness, and if you're a young child, to document PLMs, what a restlessness. If there's really daytime sleepiness without sort of any other understanding as to why that is, because that's not typical for insomnia. And then occasionally just to delineate, I have no idea what this is. They're not responding to behavioral therapy. And it helps us to sort of make sure that things are clean, sort of, so to speak, to at nighttime. And we need a comprehensive sleep history. You guys know this, and we want to assess the caregiver burden. We do this by are you sated for the parent and see, and then we ask, is this related to your sleep? Because we want to see, is there a consequence for the parent? And we love sleep plots, but we rarely get them. If you notice, we're hardly getting them, and it's just kind of disappointing. But it helps tell the story. And I had a patient yesterday. I couldn't pin them down to when does he actually fall asleep? I don't know. So you can't do bedtime, maybe you can't do some other things when you don't have that detail. But when they are, committed to a sleep log, they now have to write it down, and at least in the last week or two, you can take that information and work with it. And so a lot of times the sleep psychologist will employ the use of these things. Okay, so now we're going to start with cases, and I want your reaction. I don't have the fancy buzzers that Eric has, so we're going to just go with it. We have a 14-year-old menstruating girl. She presents after resolved sleep apnea. True story. Status post TNA due to continued trouble falling asleep at night. So mom doesn't want any medications, but she's like, look, everything's fine. Just continue falling asleep problems. Some nights she falls asleep quickly. Other nights it takes her 1 to 2 hours. And if she doesn't fall asleep right away, she's really tired the next day. Some RLS symptoms on those, not those naps, I'm sorry, those nights. Sorry about that. So yeah, put this together last minute. Eric does that. Ferritin is 68, so we checked it last time. She has some RLS, okay, we're good. History and exam otherwise normal. She drinks caffeine-free pop at dinner only sometimes, and this is her sleep-wake cycle. 10 o'clock to 10 to 11, weekend and school days. An actual falling asleep time is not bad, 10:15, but can be as late as midnight on some nights and weekends especially. And her wake time is not too far off, 6 to 7 to 8 on the weekends. What's the most important next step? What would you guys do? Bedtime melatonin, schedule PSG to reassess apnea, recheck ferritin, and give iron, not give in iron. Check to ensure her pop is caffeine free.
DNA. How long ago?
Oh, she just came back. She's now like 2 months post-op, and she's not snoring, and all that good stuff. And her mom didn't really know she had sleep apnea. Kind of a poor historian.
That was a ferritin check.
And the ferritin check was just this past visit before her TNA. We saw her first, and then we got, because of these RLS symptoms, we got ferritin. And I'm not gonna, and this is sort of I have to admit, this is sort of a tricky question. I just didn't know how to ask it. Check to ensure her. So what happened was the mom kept insisting this child has caffeine, no caffeine. And it turns out she was having Diet Coke every night. This is a very true story. Diet doesn't have caffeine in it. That was the knowledge and the belief of the parents. So some of the time we have to do some.
It's decaf, right?
Yeah.
Just kidding.
It's not even the decaf. It has no sugar and no calories, so it must have no caffeine. But nobody turns to it. And some kids, by the way, I was a fool. I didn't know that some kids didn't have caffeine until I turned it on. I can't believe there's caffeine in here. It's orange. And so I fall into that trap too, that trap of thinking that we lump things into caffeine free or something like that. So what was happening on those nights, and we had the aha moment. Those were the nights that she couldn't actually fall asleep, and all we had to do was remove the caffeine. And that's a true case, and that goes along with sleep hygiene. So there's a very, very basic kind of sleep intervention, right? And so caffeine, the American Academy, just to let you know, they had a ton of problems with energy drinks and caffeine, lots of admissions for tachycardia and some toxicity related. And so the recommendations is no caffeine at school. That's well and good, but you don't know what the home environment has. And we have these tablets that will go all over the house and find caffeine. Woo, there they go. So, so they're not at school and all this other stuff, but they're at homes. Next case, 16-year-old boy presents with trouble falling asleep at night. Tried multiple medications, nothing is helping. No snoring or other symptoms. No night wakings, no caffeines or substance. So we're saying no, so believe it. And by the way, if you ever get a board question, if it says no, believe it, like for the most part. And that's where I am learning this as sort of an item writer now. I can't ever talk about sleep board review with you guys for that reason, but they're very picky about this situation. If you say normal exam, it is normal. So just know that. You know, you have to, normal is normal. And that's why I wrote it like this. So mom removed the TB, she removed all the stuff. So great sleep hygiene, exam is normal. And this is his sleep-wake schedule. Bedtime, 10 o'clock on the school days. He falls asleep at 11:30 and his wake time is 6. So he's a little short asleep. Weekends, 12 a.m., 12:30 he falls asleep, and 10 a.m. is his wake time. What's the most important next step here? Bedtime, melatonin, morning light therapy, regularized wake sleep schedule. And it is C. It's so important to regulate. When you see this wake time, and this doesn't seem so far off, but there's a huge lag and less of a lag on weekends when he goes to sleep later. We know that this is a social jet lag situation and that he's never going to really fall asleep on time unless there's that, unless there's this, unless we address this. You can put all the morning light you want, it won't work if you don't change the schedule. You can put all the melatonin you want, it won't work unless you change the schedule. And that's when a lot of people come in and say, I've tried the melatonin, it doesn't work. There's not great evidence. If you look at the Academy guidelines for circadian rhythm disturbance in general, the combined approach with scheduling morning light and melatonin works the best, but you can't do anything without regularizing sleep schedule. So if it's one intervention, like if they leave the clinic, you want to say, wake up at, something. So we'll get to that. And for those in the room who think about circadian rhythm for the first time, or if you've known about this. So if we have a normal sleep-wake schedule that's according to sort of social norms, school norms, etc., we fall asleep quickly and we can wake up okay. But in a delayed setting, and we have some patients who have insomnia with circadian factors, and this is the illustration that this case is that we fall asleep a little bit later, harder to sort of wake up, morning sleepiness, difficulty waking from sleep, pretty classic, tiredness in the first period, and they have an overall restricted schedule and they're tired the next day. And so they may come saying, my insomnia is bad, and it's our job to say, is this insomnia and what other factors are playing a role? Circadian in this case is playing a major role. There we go, little bubbles. Now applying the two-process model. So we're going to talk about anybody want to explain the two-process model before we go on? Asleep. I'm going to quiz you because you had this lecture last week, I think. Two-process model of sleep regulation are
sleep and drive. Melatonin cycle. Circadian cycle.
So yeah, you got process S and C, right? So there's homeostatic drive to sleep down, your propensity to fall asleep. And then your
sleep pressure, which is going to be determined by time of day and the time from last sleep. Which is
Time from last
usually-
week, yeah.
And then you have your circadian cycle, which is based on time of day.
And more time dependent, yeah, you have one that's more, time awake dependent, and then the circadian dependent in terms of, so those are the two processes to help us, and when they're aligned, things work very well. Sometimes we have to explain this to patients because they are misaligned, and we're trying to align them a little bit better. And so what are we doing here? You were talking about the sleep drive, like you said, so the time that we're awake, if we get enough sleep, our sleep drive is minimal, and then it increases to the end of the day where it's maximal. And then it dissipates as the night goes on. And why don't we just fall asleep as this pressure increases over time? Because our circadian rhythm is the other part, and there's an alerting signal here that sort of keeps us awake. In fact, so it's a mathematical equation. As pressure is increasing, our circadian alerting signal is also increasing. But there are certain points where there's more maximum and minimal, where one outweighs the other. And you'll notice this is the time actually, which is a great time to have a conference, is that this is where our alerting signal beats our sleep pressure. And then what will happen come post-lunch is that our circadian alerting signal is sort of plateauing a little bit and our sleep pressure wins, and we have to sort of dip. This is where a lot of things happen, sort of in the, mistakes happen. A lot of siestas happen overseas, and mistakes happen in the hospital. So we have to pay attention to those sort of things. And then guess what? What happens at the very, very end here is this forbidden zone of sleep, because our alerting signal is maximal. And this is when some people with insomnia will try to go to sleep, and we say, don't go to bed at that time. And then, of course, we know that falls off, sleep pressure wins, we go to sleep. And what keeps us asleep is also circadian. So, we brush off our sleep pressure, but what keeps us asleep? The circadian drive is extremely well. We stay asleep much better. And so if things are lining up properly, we're good. Elevated sleep drive, proper circadian timing. And we also know that there's other things besides, that's why the two process model is a theory, right? And it says it's a model of sleep, and it's a true model. Those are the processes, but there are other things that affect our sleep, obviously, medications, caffeine, etc. But if we have a low sleep drive and proper circadian time and high physiological mental arousal, we're not going to sleep very well in that combination. So going back to our case, how do you fix it? So yes, regularize the sleep schedule, but what do you do? How do you do it? She lets him sleep whenever, right? We've heard this before. I let him sleep because he's so tired. I just let him sleep. The weekends, I just don't, he needs to sleep, right? He needs to sleep. Sometimes he naps after school and cannot control these naps. So what do? You can choose more than one. Go to bed at 10 p.m. all days, even on weekends. Melatonin 1 milligram. Wake up at 6 a.m. on weekends. Wake up at 7 or 8 a.m. on weekends, and address napping behavior.
ABD.
Okay, all right, so we got some things. I will say, and I'm sorry that I'm going to disagree with you on this one. And I know that it makes sense, and it does make sense eventually to do this, but for now, and I know it's really the next step here that I should say, but I agree with you that eventually that should happen. But why not? Why don't we say go to bed right now at 10 o'clock? It's really this forbidden zone here, because he's not capable of falling asleep until when? 12:30. So if we're telling him, or 11:30, if we're telling him to go to bed before he's physically capable of falling asleep, then we're not doing him a great service. And in fact, I will start with the adolescent and build rapport by saying, I want you to go to bed later, and I got a friend. We're good. And then I was like, but on the weekend, I want you to wake up at 7. And then, but I always start with that. I thought we were friends, but we're not friends anymore. But what are we doing? One of the premises of insomnia is not to go to bed until you're sleepy. And if your circadian rhythm right now is not aligned, we don't focus on bedtime. A lot of people focus on bedtime. A lot of parents put, when do I have to put my child to bed? When do I have to, because they can control that. Sometimes they can't control the warnings. But that's where we need to make an intervention. That's where we do the light therapy, and that's where we need to regulate schedule. And we can't seem to control it all the time. But then, do we want to wake them up at 6 o'clock? We'll definitely lose a friend there. Now, if you go to the military, you wake up 6 o'clock every day, you won't have any sleep problems and your circadian rhythm will be on point. You go to sleep, you wake up. I say this because we have military personnel that come in and ask them, if they're your patients, how they slept when they're in the military. They have no insomnia, right? They're going to sleep. They come back with PTSD, unfortunately, but they have no insomnia. They're trained that I sleep whenever. That's what we're doing when we're sleep training. And we're regularizing sleep-wake cycles. But we don't want to do that now. And you'll notice that Dr. Carolyn Bland, the same thing, she will not focus on bedtime because then there's this emphasis that you got to go to sleep. And what does that do? It sort of causes some frustration, right? And melatonin, yes, it can be hypnotic and chronotropic and light therapy, great, all well and good, but not going to happen until, again, we regularize the sleep-wake schedule. I compromise, and I sometimes will ask the adolescent or teenager, when do you think you can wake up on the weekend? And wiggle that between 1 or 2 hours of wake time on the weekdays. Because we know they wake up at a pretty early rise time for high school, and there's some movement to change those times for adolescents. And we probably need to do that because they're not getting enough sleep. But we want to be more realistic too.
But then they can't play basketball.
Yeah, then they can't play basketball, right? And then we want to lastly address napping behavior, because sometimes he needs to sleep, right? But we'll never fix this problem if you don't do that. Why is that? Let's go back to the 2-process model of sleep. So you have your pressure that builds over the course of the day. And by the way, this is a small pressure, but this teenager may not be getting enough sleep, so he may be starting pretty high. So by the time he comes home, this pressure is pretty high. And that's why over here, and so you might be a higher pressure or something, and then they may nap that dissipates that pressure. They start kind of low, and their circadian rhythm is really winning again here when their pressure is really high. So they're just really off, and they're not in sync with their circadian rhythm. Okay, good. Can we move on to the next case? All right. So we have a 10-year-old ODD, ADHD, depression, anxiety with past trauma and abuse at age 3, now adopted with his current family since that age. He's on several medications for behavior, and this is I think a true case, manipulated a little bit because I couldn't remember all the details. So he's on Adderall XR, and he's Adderall 3 p.m. For his behavior, and he's on guanfacine 3 milligrams BID, which helps us significantly with his behavior. He's also on Seroquel 50 milligrams at night for his sleep, which has helped. He takes all his medications at 9 p.m. He denies any nightmares. Why did I say that? Because he's got PTSD, and we always have to ask about how that is going. If there's some nightmares or something, like we need to address it. He falls asleep around 2 p.m. every day at school, and teachers have noticed that he needs better sleep. So they're telling the parents, your child needs better sleep because they're sleeping at school. Very common that we'll get that. And they're asking for help with insomnia. How do I put him to sleep and get him more sleep? His Epworth is 14. He wakes up 1 to 2 times a night seeking the parent. The parent needs, and he really needs the parent to fall asleep nightly since the age of 3. There's a lot there, right? But there's always a lot there. We don't see simple cases anymore. We talked about this earlier, and we see more complex cases. And so, let's unpack this a little bit. He's had some trauma. He's had psych comorbidity. We want to make sure that those things are stable, because in the insomnia literature, we treat everything. We don't treat it just one thing and hope the insomnia goes away. We treat the insomnia and the comorbidity. And so the other thing is he's on medications that might make him a little sleepy, and his Epworth is high. That's not typical for insomnia. So we know that there's something else playing a role here. And he's seeking parent, and he needs parents to fall asleep. And so that we need to unpack as well. Okay, so what is your initial approach? And I'm saying initial for a reason. Long-term, there's some other things. So bedtime is 9. He falls asleep at 11 with a parent, I should say. Wake time is 8. On weekends, just maybe a 1-hour difference, and he does fall asleep still around the same time, because medications are all in the same time, and his wake time doesn't differ much. So what's your initial approach here? Behavior, go ahead. C. Okay, and why C?
Just the extended with these extending at 3 p.m. The sleeping during the day is happening before that. So 1, there's potentially lasting effect into the night, and 2, probably should take it sooner so that.
You can cover maybe that sleepy period and thing I agree, and everybody agrees with that approach.
I'm targeting the needs parents to fall asleep nightly.
Perhaps, sure,
That's like a behavioral thing.
yeah.
But I agree. And then the bedtime is incongruent.
Uh-huh.
2 hours of laying back to sleep.
Right, so what would you do for that? What would you do?
Bedtime.
Maybe shift bedtime, we would call it bedtime fading for children, and so I agree. So even if we have these complex psych insomnia cases, and we do, the principles stay the same. We employ typical insomnia management, but we just tailor it according to their psych needs, and so we're co-managing oftentimes. And we have realistic short-term goals, and one of my questions is, will this child be able to sleep on his own? You know, maybe not right now. We have to be mindful that with children who've had trauma, especially, and especially those who've had PTSD, and those who have had, you know, different foster situations where there's an attachment problem. Sometimes that co-sleeping is their sense of security, and because they don't know any better. And we don't always want to address that because there may be some comorbid anxiety. We'll get to that. But maybe right now it's not maybe on our things to do, right? But it's on the back of our mind. Okay, so we have some co-sleeping. But one of the bedtime, the strategies behaviorally, like you said, sort of bedtime fading. We still employ this. Why? Because we don't want him laying in bed for a couple of hours, not sleeping. Exactly. We're teaching his body to sleep. And the more time he's with co-sleeping and kind of doing some struggle around sleep, the more time he'll have insomnia. And we don't want to perpetuate that issue. So we are going to do that. And then, you know, and then what are we going to do with the medications, the Seroquel, guanfacine, and other strategies? And so, and I agree with you that we should probably look at the timing of things. And I would also look at the guanfacine too. So, you know, what is he doing? At his, let me see if I have it. Okay, there it is. It's like this slide. So this is where he's falling asleep, where his circadian drive is not there. Alerting signal is very low. And so something's happening. Maybe the guanfacine is winning, or his Adderall isn't covering, those types of things. So we never take off medication, especially psych medication, but can we say, does he need his morning dose? Can we maximize it at night? If he needs his morning dose, can we reduce it? Can we remove the Adderall? Just like you said, can we cover that? You know, if he has that low, can we cover that? And so we're still giving him the appropriate medications, but changing the timing. We're really good about that in sleep medicine. Timing of medication. Good. All right, so 7-year-old, the next case, ready, guys? I can just keep going, so I have to be sure you guys are okay. All right, so 7-year-old male with autism, and there, you know, we used to call it, you know, lots of different things, but it's autistic spectrum disorder, or ASD, and I think it's on the spectrum. So he's on the spectrum. He's never slept well. Is that surprising to hear that statement? Probably not. In children with autism, you know, there's lots of high rates of insomnia. He's got difficulty going to sleep and staying asleep for many years. They're currently giving melatonin plus the clonidine for ADHD at 7 p.m. Lights out, sleeps on his own at 8 p.m. And he wakes up at 4, he can't really return to sleep. That's it. He's very restless during sleep. He seems tired earlier and often may fall asleep at 7 p.m. He's tired a lot during the day. So here's his bedtime, wake time. He's going to sleep pretty quickly because he's had difficulty before, and that's why he's on the clonidine. But now he's pretty quick, and his wake time is 4 or 3 a.m. to the detriment of the parent who would like to sleep more, especially on the weekends. All right, so what's the next step? Give a longer acting clonidine. So we're doing short acting here. Stop melatonin. Get a sleep study to evaluate for something that may be waking him up. So sleep disordered breathing for you guys, or restless sleep disorder. Try to regularize sleep-wake times in behavioral therapy, or change the medication to a longer acting formulation, or reduce the clonidine or redose the clonidine at 4 a.m.
I don't think he's getting enough sleep.
And you would be right in saying that. The only thing is, and this is exactly why I put this case up, is to illustrate that in children with autism, they don't sleep that much, some of them. And there's a lot of evidence here. Why is that? We don't know. And so our expectation of their sleep might be around what their norm is for themselves. And that's hard sometimes to find. And it may not be in typically developing children, we expect this much sleep. In children with autism, we may not expect that same amount of sleep. And sometimes you have to have that conversation with the parent and say, and they don't like to hear that because it's hard. It's hard to manage it. And if they were 3 years old and they were running around the house, well, they're getting into major trouble. But we have to say, find a way, find help. You got to have a village with these kids sometimes, especially at nighttime for safety reasons. Because some of them don't sleep that much, and it can be difficult. But can we maximize things and try to maximize? We probably could. And so in this case, it's trying to regulate. I wanted you guys to consider the possibility of an advanced circadian rhythm here, given that he's falling asleep sometimes very, very early, 7 p.m., for example. Clonidine doesn't work that fast. And so we wanted to say, well, then that's maybe sleep pressure, circadian something. Why is he falling asleep at 7 p.m.? Of course, you could say he's sleep deprived and he's, sometimes sleeping too, but that timing is really critical. And he's never, ever, ever able to sleep after 4 o'clock. So there could be an advanced rhythm here, or early awakening, which is very, very common in children with autism. So we have early AM wakings that we see in advanced rhythm. We see that in autism. We see these a lot in teenagers that can't fall asleep and then they can't wake up. So we're always thinking about the presentation of insomnia. Where are they living in their circadian phase? I saw one yesterday who has this schedule. And let me tell you, this is going to be a bear. I can't even figure out where his melatonin onset is, right? Like we don't even know. Unless I put it, made it spit in a cup and did my melatonin. I have no clue what this guy is sleeping. And sleep labs would be helpful here, so I'm going to give them that, but who knows if they'll return it. But this is the hardest one, but we see that a lot with neurodegenerative, especially in our elderly populations, and we don't see as much in our children's population. All right, I'm going to look at clonidine for a second because this is our time to review it. Its indication really is ADHD, but it has a calming effect for sleep. In order to sleep, sleep is behavior. We have to be calm. So that's how it sort of helps these children. Some of the children who can't calm, who are very fidgety. It may also have sleep onset effects. And in some studies, I don't have it on this slide. It doesn't last that long, peak effect 2 to 4 hours, but it may not last the entire night for very, very long sleepers or children. And so it may wear off. And there are people who redose it. So one of the questions was, redosing. He would not do that at 4 o'clock, given the properties of this medication. He would not, yes, it might help him to fall asleep, but if we're not addressing the circadian, it may not. If, however, he was waking up at 2 or 12 or something else and we wanted to redose, there are people who redose medication. I'm not a big fan of redosing personally. Because I feel like it involves some behavioral aspects that sort of, that in some cases you need to redose medication, or you can use a longer acting one.
Wouldn't that be an inappropriate time to redose?
It would be very inappropriate.
Because,
I agree.
just by itself, by the mechanism of action of quantity, take
Correct.
an hour, so you need to advance that to 3 a.m. if you're gonna.
Exactly, you're gonna wake them up at midnight, sort of give them another dose, right? And it might be better just to say, and exactly, so when we're redosing, Sonata is one of them, short acting, but there's a window after which no more medication, because now we're gonna have issues. And what you might create is a nap in the morning, and then it's just, it's all over the place. And we'll actually see those patients come in where they're napping and sleeping and we can't figure it out, but they're putting medication on all sorts of different times. And so it's like, we want to consolidate that to the nocturnal period where we want them to sleep. Absolutely inappropriate time. That's why I did it. So I did an egregious time there. I'm like, okay, you're not going to pick this one because it's going to be 4 a.m. It's not going to work. That's not going to work. Okay. No well-designed studies in pediatric insomnia. It's open label for insomnia at night for children with autism, and that's why it's widely used. And there are improvements mostly with sleep onset, but sometimes night wakings as well. All right. Okay, fewer night wakings with neurodevelopmental. You see how little these studies are. We don't have good studies in children. We have very little evidence. Kind of like our children, there's little evidence, right? Okay. Which treatment has been shown to reduce sleep onset, latency, nighttime, improve sleep latency in young school children aged short and long term? So it's a mouthful. Improve all sleep, short and long term. It's always cognitive behavioral therapy. It's always cognitive. What a doubt. So none of these medications, and this is why over and over and over again, if you read any pediatric insomnia literature, it's all about behavioral therapy. It's very little on medication. And I try to gear this talk towards that, but I'll tell you, we are pushed sometimes, right? They're coming to sleep clinic. We are sometimes our last resort. And we'll show you and illustrate some of these cases. But we do have the help of a sleep psychologist, and we're very lucky for that. Not every center has that. And she's very good. Children with autism, how many have sleep problems? Would you guess?
3 or 4.
3.
3 or 4, right? So yeah, 3 is right. And you know, sometimes it feels like the 80 or 90% because they're always coming to sleep clinic, but nonetheless, there are children with autism who sleep fine. And they have a lot of different types of problems: sleep initiation, or maintenance, or irregular, or early morning wakings, or poor routines. Sometimes it's hard for them to routine. Sometimes they're overly routine, right? I need all these things to sleep, and then you know, or they're hard to manage. And then the tablet's given. You know, I was given, you know, we're doing the study in media use. One of the development behavioral pediatric fellows is doing the study. So she's, you know, media use in children. And so we have all these conversations, but they're, you know, it's really, really, really hard to take these tablets away from these children at night because now they have this thing and it's almost like a punishment when you take it away. And so I don't know what it used to be like before tablets. It seems like just a new world that now we have to adapt to. So anyway, those routines are poor, and it's very hard to undo that. It's very, very difficult to undo that. And they're very much prone to behavioral insomnia in childhood. They have circadian rhythm disturbance. Just know that they do have abnormal melatonin regulation. And this is why perhaps a lot of them respond very well to melatonin. It doesn't seem that their melatonin itself is not present. It certainly is, but they have so the response or something to melatonin sort of in the regulatory aspects, and I can bring that literature in, but once I understand it myself. So, and then the fancy other literature about this is that they also have changes on their EEG, not beknownst to us. When we read polysomnography, I'm always trying to look for it, right? We're always, you know, I try to look at EEG all the time because there's reports in the literature that the REM sleep is off. Now this is going into fancy EEG analysis, things that aren't, you know, so clean on a 30-second epoch. But there is literature that says their REM sleep is also up. And then they don't sleep a lot, prone to reduced sleep requirements. So with that, their sleep inherently may not be normal, and they may respond to melatonin, and then we want to also give them the appropriate sleep for their needs.
They use like Ramelton in these kids.
They haven't, no studies, but it's a good thought because we're looking at the melatonin receptor. There's a lot of thinking about using different things. I haven't personally tried it simply because we have such a hard time getting it from insurance. And then I don't know if it's in liquid form. All these children have a sensory issue, and then trying to find the right medication. If it's liquid, it can be stuck in. If it's a capsule or a tablet, it may not be. So those are other issues with some of these children. Approach to insomnia. So we screen for sleep problems at each visit. Refer for sleep services clinically indicated. This is coming out of the 2008 recommendations. Emphasize behavioral strategies and frequently require medication. This is coming out of this review of treatment strategies for complex behavioral insomnia in children with neurodevelopmental disorders. I thought this would be nice. It's much more than what do you do? It's going out to the sensory things, quality sleep environment, maintaining a sleep-wake schedule. This is talking about temporary delay, which is bedtime fading. A lot of people don't consider that as a treatment, but it is something to consider. And then, so they do put this in this table, and then gradually move. So this is the sort of treatment for what? This is bedtime fading, right? They don't say that, but they say difficulty falling asleep. They don't call it bedtime fading. This is true bedtime fading. And then don't allow the child to make up for lost sleep by going to bed earlier or sleeping later. This is a huge one for parents, and that's especially when my child has autism and they're sleeping until noon, I'm letting them sleep because number one, they don't want to deal with their behavior sometimes, and number two, they haven't slept, right? But that is the very, that's our adolescent case. We're trying to do that. So there's a lot of great stuff in here. I think it's helpful when you're ever giving a talk or something in the future to can think about these things. And then of course, parent-child interactions. You don't want to engage with children or fight with children, or even say go to bed when you're angry with them either. We don't want to use it as a punishment. And oftentimes parents don't talk about that. They don't talk about that parent-child interaction, but sometimes we'll just say it. Keep the stress level down, all these things. Okay, and there's bedtime pass. Is it time for a break? What time is it? It's 9:02. You guys want to take a break or keep going? Yes. Okay, 5-minute break, and then I'll also get a little bit of coffee, or we can chat.
No, I need to figure out.
This week?
Sorry?
You and I this week, right?
What's it again?
No, call.
Am I on this week?
Yeah.
Okay, yeah, call. Or don't call. All right, so, Layla, right?
Laura.
No, Laura and Layla.
Oh, sorry.
And Carla, so, well, okay, so a lot of A's here, or anything's in A. Check us. You guys do with the pediatric. One month? Yeah.
I went with Moshe last week. That was cool.
Does Sally also have a clinic at the same time?
So I had Lake and then what?
Interesting. You go to Westlake now for Pete?
Oh, yeah.
Oh,
So what happened
so
was-
Christy's not doing it anymore?
No, you know what happened was Christy has to go to Metro now
Oh.
because of the, so what happened with Metro is that they didn't have enough specialists,
Right.
pediatric specialists only. This doesn't apply to adults. And so Rainbow partnered with Metropolitan
Okay.
to provide that service.
Okay.
So it's turned out Moshe and Christy are both doing, for pulmonary.
Okay.
Not for sleep, because John Carter's obviously okay in
Right.
managing that, so we're lucky to have him. And so because of that, and now Christy became, I don't know what the title is, Vice President of like the Metro Health Affairs.
Okay.
Her hat is, she's like, I probably have to give up this clinic. And so therefore, and Moshe wanted Landerbrook. So I also had to sort of just go, a couple days a week to see, let's text to Landerbrook. And we needed more of a West Side presence. So I offered to go to the West Side, and then Christy said, why don't I just give up that clinic and then you can have those fellow clinics and we can have those fellow clinics. And we'll
Oh, where are you?
dividing.
Probably not that big of a difference.
It's a
5 minutes.
exactly, got it. So it's like an 8-minute kind of thing.
More to go to Westlake.
It feels like a lot more. It's like, I'm in the car longer here. What's going on, guys? It's not that much. It's more mental
Yeah.
than anything. Yeah.
I want to address something real quick before I come out here. What are you going after this? Yeah, are you going to exactly studies at the SIO plan? Yeah. Can one of the business go with you? Yeah. Well, or yeah, I mean just to watch how you do. Yeah. How about that? Okay. Okay. So, Carl, you want to try to go with Zach?
Yes.
Okay, and Zach will let you know where to go. Okay. Are you staying around? Now, is it okay if Laura stays with you guys?
That's fine.
And just kind of hang out?
That's fine.
Yeah, yeah.
Yeah.
And then Layla is one of the pulmonary fellows.
Okay.
Who
all right.
actually-
I've seen you before.
Yeah, who I just found out that rotation with sleep disease 2 weeks.
Oh,
Yeah.
seriously.
So
Okay.
we happen to have like 3 learners
Okay,
here.
all
Like,
right,
yeah.
sounds good.
So this afternoon it's gonna be a pretty crowded clinic, but I think it's gonna be okay. All 4 of you.
Oh, I was scheduled with Dr. K.
Okay, yes, okay, and then
So,
so the 3 of you will be with.
You're in the VA? Or,
No,
no,
Metro.
Metro. That's right.
Okay, yeah,
Okay,
so how about that? Okay. You try to figure out a little bit, we spent some time with Zach, and then, you know, and then I will email you separately when I think about it a little bit of how to appropriately place you guys this 2 weeks. Okay.
all right, good. All right, so, and some of these principles also live with adults too, so I hope that we can apply some of those. You know, principles of insomnia really are, you can really apply them across the board. They may look scary in the beginning, and then you just dissect it out and sort of say, what can I deal with, you know, first? Okay, so let's change gears a little bit. It's not that much, but we want to review comorbidity and sleep disturbances in order to evaluate sort of the presenting complaint of insomnia. Okay, so the next kind of things and cases are going to look at, you know, some comorbidity. Okay. We have a 4-year-old female born term with a medical history of controlled asthma, uncontrolled allergic rhinitis, tried many different things, eczema, who has difficulty staying asleep. She's waking all hours in the night. She comes to her parents' room and she's an intermittent snorer. Started on melatonin, which helps her sleep a little bit better, but still wakes up repeatedly. And she can't take and swallow pills, so you can't do melatonin XR. Exam noted for eczema and 1+ tonsils. She intermittently naps 1 time a week, and on these nights she can't go to sleep. Okay, so here's her schedule. She's pretty on point, 8 to 9 plus her melatonin even on weekdays because she does weekends because they, you know, why not? They're regular about it. She falls asleep pretty quickly, and she's always pretty regular when she wakes up. Pretty typical for a 4-year-old actually. And she sleeps a good amount of, you know, 12 hours in a day, unless she naps. What's the next step here? Consider untreated asthma. Get a sleep study to evaluate for sleep disordered breathing. Delay bedtime for an hour to see if this helps with waking, so there's consolidating sleep, or consider another comorbidity. I know we just, you know, it's sort of I know this isn't the greatest question. I would not be happy with this exam question myself, but it's illustrating something. What is it illustrating? What do you guys think? Sure. And she really does have all the, you know, the one airway hypothesis. She's got the asthma, allergic rhinitis, why not the sleep apnea? So I agree with you that probably we would get a sleep study on her. I'm certain we would, right? And that's not a wrong answer. And yeah, in this case, and I really do like your answer, but I agree that it's, you know, there's some other comorbidity. I tried to find a case that would illustrate the comorbidity, but I agree with you that probably is, we want to make sure, because 1+ tonsils have large adenoids, there's a lot of other things here, and untreated allergic rhinitis. So in going back, I may have to change this, because I think that is helpful, because she has night awakenings and no problems going to sleep. What do you guys think about her intermittent naps? Age appropriate? It's age appropriate, yeah, once a week is kind of fizzling, probably okay, and so we don't want to get too hung up on that. And on these nights you can't go to sleep, very, very difficult, yeah. Okay, so what I was trying to illustrate with this case was insomnia in children with comorbidity, and one of the things that children don't tell us is why they're waking up. They just have this sensation, and there are some studies looking at the effect of children with atopic illness, whether it's eczema or asthma. Eczema is actually one of the worst things for sleep, and their itch makes them wake up. They're sort of itch, and sometimes we have to actually ask about the itching. They won't present it as a complaint. Yeah, I itch. Yeah, I itch at night. You know, yeah, do you really? You know, and your mom's like, you know, I didn't know you're itching or something like that. But if you have, and she has patches of eczema there, it could be something, the sort of itch scratch cycle that can happen at nighttime. And in fact, if anything, sometimes using medication temporarily may help with sleep in that situation, right? So things like, you know, hydroxyzine or indoxafen. ADHD children, you know, children with ADHD, I should say, we talked about, or Bill talked about, an autism spectrum disorder. There's also a group of, you know, chronic headache and chronic pain. There are definitely situations of poor sleep. And again, we have to dissect, is it insomnia or poor sleep? Sometimes it's just poor sleep, and we just want to manage it, manage that comorbidity. Sometimes dealing with the comorbidity and not exactly employing a insomnia agent. Okay, so now we're going to move on to this 8-year-old with ADHD on Adderall BID. Sleep problems are going to sleep and problems waking up for school. It got slightly worse on medication, right? After he started Adderall, but his behavior is so good that they're saying, don't you dare stop this medication. It started on melatonin as a result, which slightly helps, and he takes a break on weekends. He really tried clonidine, but had an adverse reaction. Bedtime and melatonin are at 8 o'clock, but still hyper when medications are worn off at night. He's very fidgety, restless, but no clinical RLS. Restless leg syndrome, wakes up at least once a night, doesn't require parent to reinitiate sleep, and he's an intermittent snorer. He's very hyper on exam. He has 2+ tonsils. Lots there. Going to his bedtime schedule. School, they give him a break of melatonin on the weekends. On school nights, he's 8 p.m. with melatonin, falls asleep by 10. Kind of a little bit of a delay here on wake time as well on the weekends. So what's your initial next step? Would you consider untreated ADHD and dose Adderall in the evening? The Europeans would. The last European, it was ADHD something. I can't remember now which year this was, and it may have changed, but they do promote the use of Adderall to calm at nighttime or stimulant at night. I think we have other medications to use. He's clearly failed clonidine, but there's guanfacine and some other things that could potentially help calm without the stimulant effect. But just know that there is a body of literature, at least from the European side, that says you can redose. But he's very fidgety and all this other stuff. Get a sleep study to evaluate sleep disorder, breathing, restless sleep disorder, regularize sleep wake times plus melatonin timing, and consider another comorbidity. And you would do C. And you would be right to do so, right? Because he still has some room here. Without, because what usually the next question the parent has is, what other sleep aid can you give me? Right? And we want to say, we want to kind of look at all this, but yeah, let's regularize sleep wake times. So children with ADHD, and we'll get back to that case in a second. Makeup, it seems like more than that, but maybe 5% of children. Sleep disturbances are very common in these children, and they're worse with comorbidities. So sometimes they have ADHD plus depression, etc. And sleep complaints are higher when you compare them to controls. A lot of sleepiness on waking, night waking, and delayed onset. And their actigraphy studies show that they're movers. They're like very, very restless. So it's inherent in the problem or not, it's not clear. They have many more PLMs. And so they're thought to have maybe some shared neural biological pathways, ADHD for sleep, because they seem to move a lot. And there was a group of people who thought ADHD was a sleep disorder. But it was just, if you fix the sleep, then you would fix ADHD. And there's one study in adults, if you put ropinirole for PLMs, that their ADHD improved, right? We're not going to do that, show them, but so it's an interesting coexistence with poor sleep and ADHD. But again, we're treating them two different things. If there's an insomnia, we treat that at ADHD, but we know poor sleep is inherent in ADHD, and they may develop insomnia. And our job is to sort of dissect this out. Is it true insomnia is inherent to the ADHD? And then we also know that just as in this case, if we start ADHD medication, their sleep can worsen. And this is in the ADHD literature, and that is why they say you have to talk about this and screen for sleep disturbances before you start this, but they commonly do affect waking in the morning and some other things, especially if they're using some sedative. And the patients vary so considerably that there's not a one kind of size fits all. But overall, yes, the census is that the ADHD medications do impact sleep in a negative way sometimes. One that doesn't affect sleep that much is is a medication I never use, but I wanted to include this in here in case people are interested in that. And what is our approach? Lots of things. This is the premise of why that European literature says to give a small evening dose, because of that rebound effect or crash and they're back up. But anyway, but we're also screening for comorbidities, and we're only considering sleep medication when there's really just kind of unresponsive to anything else. They're really doing poorly during the day. And we always start with melatonin. Some of these kids already started it. Okay. And then lots of things. This is for ADHD. It was written in 2013 in terms of practices, in terms, behavioral modifications for children with ADHD. We know this, and this is exactly what we do for every patient in clinic. So I don't think that this is just for ADHD. It is really, we're promoting sleep regulation. We're promoting sleep conditioning. Don't go to bed until you sleep. We're conditioning that behavior of sleep. We're reducing arousal. We're promoting relaxation. Sometimes we have to do that with medication, unfortunately, but we want to do that as much as possible with behavioral modification and comfortable, safe sleep environment. These are some of the medications used for children with ADHD. So when you see them in clinic and you're like, I don't know why they're using a lot of these. I know, I remember the first time I saw a patient with insomnia on clonidine. I thought, what? He's up for blood pressure. But yeah, we do have a lot of side effects in it, and it helps. You'll see this in children do very well with it. Guanfacine can sometimes more so help with sleep, and over time it's thought to the sedative effects maybe going away, but we do see them, and sometimes the efforts are very high. So anyway, so we're back to our case. We have this 8-year-old. This is not his sleep log because he went on vacation and all bets were off. Okay, so let's just pretend with me here for a second. But now so look at what time he's going to bed. Not good. Too early, but not falling asleep until much later. Always later. A little bit better when he's going to sleep later or when he's sleep deprived, right? But these are the nights he doesn't have melatonin, and what do you notice? His latencies and bedtimes are a little bit later. What would you recommend regarding his melatonin? Would you stay on the current dosage and take breaks on weekends? Increase the dosage and take breaks on weekends. They're taking a break on weekends. Would you stay on the current dosage and don't take breaks, or increase current dosage and don't take breaks and reassess? These are the nitty-gritty details that we get into at sleep clinic. Because they don't often tell you that they're taking a break on a weekend. Oh, yeah, it's kind of a little later on the weekend. What's going on? Oh, I just let him sleep because he hasn't slept, and yeah, his behavior's so much better if I just let him sleep, right? And so there's usually a reason why that is. I know I heard, we had this last week. I heard that if you take melatonin every day, that it's going to wear off, and so therefore I'm not going to take it every day. This case is to illustrate a concept here that I wanted to show you. And so maybe staying on the current dosage for now, but using it every day. And I'll tell you why. There is some body of literature showing that sometimes children with ADHD with sleep onset insomnia, that's the SOI on there, have problems with circadian rhythmicity. So if you take those with and without sleep onset insomnia, no sleep onset insomnia, their dim light melatonin onset is delayed. So they're not capable, or circadian rhythm is delayed, that they're not capable of falling asleep. So sometimes that melatonin is used mostly as a chronotropic agent. And if you want to regularize sleep-wake cycles in these children, you might have to use every night melatonin, even on weekends, much like we do. So it's proposed to be a delayed circadian rhythm disorder. If the jury's out, but you'll find that some of these children do. And if you get that, they sleep in longer. And off the melatonin, boy, they never fall asleep. We know that they have a strong tendency for delay. And we don't have long-term follow-up studies, but in some, I put this on here because they have continued efficacy. A lot of parents will kind of be very scared that if I do this every day, it won't be efficacious. There are some patients who you have to sort of take a break and then redose melatonin to kind of sort of restart the engine, if you will, but it's mostly efficacious continually long-term, and probably because it has a chronotropic reason. When we say chronotropic, it's really for circadian rhythmicity. Hypnotic is for sleep aid per se. Melatonin is unique in that it has both properties. the chronotropic, circadian rhythmicity, and the hypnotic in one. And so that's why in children with ADHD, at least this, in our case, illustrates that. And sometimes we will ask them to use it on the weekend and on the weekend as well. Are we good? All right, are you guys losing steam, or can we keep going with cases? Okay, all right. 9-year-old with ODD, ADHD, depression, anxiety, autism. So this is all the, just everything, right? We're missing one. I was trying to think of one, and there's a lot of comorbidity sometimes that coexist, right? So we have sleep onset and maintenance difficulties. He's on multiple medications, nothing alerting at night. Behavioral and mood are stable. Okay, that's key. Behavioral and mood are stable. Sleep continues to be a problem. He's doing well in school, not tired or fatigued. No snoring, RLS or parasonic. Takes 1 milligram, it's working great. And he's working with the best psychologist in town, Dr. Gerald Lanzis, and now has a set sleep schedule. Sleep-wake patterns are good for him. He has intermittent sleep onset delays, intermittent waking, getting about 8 or 9 hours of average sleep at night, and seeing a difference in his behavior. So a parent asks, what are the chances things get worse overall with the sleep and mood? What is your answer? Is it due to subclinical insomnia reassurance, encourage continued sleep scheduling and monitor for worsening of either mood or sleep in the dress? Be given, and I wrote this, and I'm sorry last minute, so I'm sorry for the run-on. That's a big run-on. Be given sleep problems persist, would obtain a sleep study just to be sure, because of sleep maintenance problems. Would encourage more sleep to aim for 9 hours consistently by increasing melatonin. Because for his age, he's not getting sufficient sleep, right? School age needs at least 9 hours. Adolescents need at least 8 hours. So
Usually, patients with autism might not get that much.
exactly. So if you find that sweet spot, and that's what Carol Elena said. She's doing sleep scheduling, and this is working. This is kind of working. And if you notice the next day, doing well in school, he's not tired of sleep. He doesn't even have insomnia. Yes, he has poor sleep, and he's not going to have perfect sleep. And that's the expectation you want to have when we're having these dialogue. It's not perfect, but it's not insomnia. And so we're happy with how they're happy. Mom's really scared. What's going to happen here? And the answer is it's subclinical, right? And once we get to a subclinical case, we're good. We don't have to see it, but what we're doing is we're watching for comorbidity. We're watching to make sure that things don't get off track. Why is that? If you worsen mood, you're more likely to have recurrent insomnia. If you have insomnia, you're more likely to have recurrent mood problems. Bidirectional relationship. And a lot of these disorders have bidirectionality to them. And so if you have sleep problems first, you can develop psychiatric disorders. All of them have higher odds of that, especially generalized anxiety disorder. And the same with if you start with a psych disorder, you're more likely to have sleep disturbance, sleep problems in general, but insomnia is being a big one here. And your odds are pretty high. If you don't treat them longitudinally, just kind of let them go, you don't address something. So we do address problems when they arise, and that's what we tell. When you start to see new problems, I want you to see. When you have insomnia, I want you to return to this. Sort of that kind of because they do have the risk of returning. All right. Now we're going to move into a younger child, 14-month-old female, otherwise healthy, born term, GERD on medications, never slept through the night. When they were 1 month old, I knew we were never going to sleep through the night. You've heard that, right? Sleep onto this, okay, but she's up 2 to 3 times a night. Parents were so tired, they end up having her sleep in the bed with them, and they're not sure. They noted that she doesn't wake up when in bed with them. That's a key illustration. She does not wake up when in bed with them. One of the biggest telltales of maybe a behavior versus something else is, do they still wake up? Their response to their awakening could be behavioral, but do they wake up? She doesn't wake up at all. At sleep onset, the parent is there and cannot leave the room. They have tried the cried out method in the past. The patient cried so loud one night, waking up the other kids to the point of throwing up. And that can happen. No snoring, mouth breathing, restlessness. She sleeps perfectly when sleeping with the parent. No daytime problems, but parents are tired. Regular naps from 12 to 2. First of all, is this insomnia? And let's say it's been going on for, all her life, right? Is it insomnia? It's not insomnia for her, but it's insomnia for the parent. So if it affects the parent, it becomes insomnia. So unfortunately, it is a chronic insomnia, and behavioral insomnia of childhood is lumped into the chronic insomnia disorder now. And usually 14 months are on point. They're not sleeping in or doing that. And you actually probably at 6 a.m. here because parents are really tired, and they're always up at the same time, no matter what time they fall asleep. 6 a.m. probably, I put this out earlier, but they're always with the parent when they fall asleep. What's the next step for this 14-month-old? Would you do melatonin? Would you increase her GERD med if that's the reason for her waking, or would you do behavioral therapy? And would you do behavioral therapy? Her GERD is probably not waking her up if she's not waking up while in bed. She's sleeping perfectly when she's not with them, she wakes up when she's. So we have that, we have a sleep association. We nailed it. And then melatonin is not indicated at this age, nor would it be helpful for night wakings. So the big behavioral insomnia of childhood, the principles are very, very, very simple. Practice is challenging. When you have this kind of presentation with the child throwing up, do you think that the parent is going to say, yeah, I'd like to leave the room? What? I don't want this to happen again, right? They're scared. And we'll talk about the Cryo Method. So first, we're going to talk about what this is. It's a sleep association. They are conditioned to sleep only with the existence of their parent next to them, or touching them, or rocking them. Sleep association can be pretty problematic. When it becomes problematic, it becomes an insomnia disorder. And in this case, you see sort of this parent holding the child. So this is the conditioned response. When held, I can sleep. Put the patient down or wait. Oh, okay. What happens? Wake up. If by chance they sort of just sneak it, walk away, what happens when they go through their REM cycles? They wake up, I need the condition to return back to sleep. They need the same conditions to return back to sleep. So that sometimes the only presentation, as in this case, is sleep maintenance insomnia. And we're thinking, okay, maybe it's something else, but you have to ask, when they go to sleep, are you there? What conditions are around going to sleep? Because if they're coming back to sleep with parents, they need those conditions to go back to sleep, and you have a sleep onset insomnia or sleep maintenance, sleep association problem. This is especially hard for infants because infants maybe are used to nursing, and then now they're trying to wean from nursing, but they still need the nurse to be able to fall asleep, and it's hard to sort of break these associations, but it can be done. The more independent the sleeper is, the better their nighttime sleep is going to be. Goals of treatment is to eliminate inappropriate. That's it. How to do it. That's the challenge. The other behavioral insomnia is limit setting. So once they learn to say no and they can push their limits, they may push their limits at bedtime. And this is that really stall the curtain calls. I want another drink. I want mom or dad. I'm hungry. And they know how to get their parents, and especially when they are when there are some medical issues or something else, because some children will learn that now they can get sort of by with something else. My son has done this to me. I'm hungry, right? Like, and my husband will, oh my God, how can you let him sleep if he's gonna not eat? And I'm just the cruel mom. And he does. He goes to bed without eating. Bedtime is for bedtime. He needs to eat. I know that sounds really cruel, but that's how they limit. They push their limits around bedtime. Most obviously, they're very, very hungry. I'm not going to starve my child, right? So, but they push that. That I want this, I want that, or they'll say, "Oh, I've had, I'm scared," right? And they very well could be scared. So we want to be real careful about, making sure that they feel safe and comfortable, but also not be pushed by limiting bedtime, because some of them are very, very good manipulators. And then if you have a parent who is passive, they're going to be easily manipulated. And then you have to do more parent skills there. And so reduce undesired bedtime behaviors and encourage the parent to have limit setting. Okay, we do a lot of parent coaching. We do want to acknowledge their stress. These parents may come in very, very tired. Okay, they could be working parents, they're up all night with their child for various reasons. They could have 3 children that they're up with. They're very, very tired. We want to acknowledge that first and foremost. We want to sort of coach them through, Because it's very easy for us to say, put them down, but then when they're there, there's that real stress. And sometimes you can imagine too, the stress with, there's marital stress, there's a lot of things, and sometimes there's a lot of counseling involved. Sometimes there's a lot of tears and tissues in the room. This can get pretty bad. And that's why it's called insomnia. And you have to have consistency. If all parents are not on the same page, behavioral therapy does not work. And in fact, it kind of confuses matters. So there could be the bombing child whose dad wanted the cry it out method. We finally need to put an end to this. That's it. I'm done. And the mom said, "How dare you do this to our child?" Right? And so now we're on polar opposites, and we have to sort of. This is sort of the parent coaching we're dealing with. And so I don't know if we've had this level of insomnia in our clinics. Have you guys had this year? Okay. All right. Maybe you have. I mean, we've had, this happens every now and then where they come in and they're just spent. This is a real thing. This is a real case. I have too, right? And this is very humbling. This is sleep time, right? So you just sort of, but it helps us be mindful of what other people are going through. And then remind them to be patient, and then remind yourself, because it's going to take time. It's going to take time.
I had to text my wife, like, I think my daughter's manipulating us. Like, it's bedtime confession.
Bedtime confessions, right?
Yeah.
Bedtime confessions of the sleep doc, right? And we should write a book about this. All of us who have the most horrible sleep, right? Their children.
My daughter was very manipulated that way. The one very interesting thing was that she has asthma, and during the winters when she had a lot of cold, she was having a lot of symptoms. We had her flow in, but she would have a lot of cough at night, and it would always lead to throwing up, but never in our bed.
Oh, how interesting.
So I was like, what is happening? Is she maybe doing this? Maybe it's just so she's more comfortable. But like when the nights when she was coughing and she was throwing up, sometimes if she was sick, we would bring her to our bed. But she never had.
Yeah, never had that.
In our bed. So
yeah.
We still don't know. It's gone away. But
I'm glad it's gone away. Yeah.
it's one of those things.
It is one of those things. Like there's a level of comfort there that so you don't know if it's manipulating or uncomfortable. So I'm not scared as much, and who knows? Yeah. And it's always that sort of fine line. I've had children come to me when they're sick, and I'm worried about that. Right? They're going to stay in my bed with me, and so make sure that they're not. And yeah, the manipulation is there. My son was post-op, and so I wanted to make sure he doesn't bleed. You kind of worry, your mind goes crazy. And so what happens is subsequent nights when everything's fine, he comes right in my bed and he's like, "I'm sleeping here." I'm like, "No, you're not." That was one time. Oh, Mom. You got to sort of know. That was only one time there. Okay, so behaviorism, and I'm not a behavioral specialist, but we have to know this for sleep. We do sort of classic conditioning and operant conditioning, sort of these models of, we know classic conditioning, and we know that we can recondition, if you will. What we're doing when we're doing bedtime baiting and all these other things is we are conditioning. That's essentially what we're doing in these small little things that we're doing. So Pavlov's dog was this, Pavlov was a scientist. He had the bell to stimulate. And at first, the dog just looked at him like he was nuts. You want to play? That's fun. But then he put the food next to the bell, and that became a condition. And then he started to salivate. So the salivation came. Now you remove the food, and with the bell, the salivation came. So that was a conditioned response. We'd like that to be the bed and sleeping, that same positive association. And then operant condition is voluntary too, is sort of a reward or response, and it produces voluntary behavior. So for example, this rat pushes on a lever, eventually finds food coming out. So it learns that when I push on this lever, food comes out, pushes on the lever. What happens with parents is that they don't realize it, but they are conditioning their child to have the behavior of wanting to sleep with them because their reward is their parent. So they're if I cry, my parent comes to me. So then they cry for their parent. They wake up for their parent. They throw up for their parent. They get the reward by the behavior. So we don't want to reward the behavior of getting up out of bed as a parent. We want to exchange that reward for something else. And so what the psychologist may do is find different ways or strategies, or we trick their brains into some classic conditioning kind of ways to sort of sleep in bed without the parents. There are some rewards for older children like this, like a 4-year-old, but the parent is a much better immediate reward than any Lego or any other game that you can promise them. They want that immediate attention and reward, and the attention of their parent is so rewarding at that age. It's nothing else matters, right? So, so these are sort of the principles of behavioral strategies. These are some general behavioral strategies which we talked about. And then there's the behavioral interventions that Carolyn Landis, for example, will do. The unmodified extinction, meaning I will ignore that behavior because I don't want to reward it, is sort of like the cry it out method, right? So you can cry and cry and cry, but I'll never give you the reward of me coming in the room and putting you to sleep. And that extincts that behavior because they will no longer get that operant conditioning reward, right? So I'm not coming in. That is the sort of cry it out method, but some parents who have done that have found that their children cry to the point of vomiting, or, I mean, I've had a child come in where they like hit their head purposely, and they're like, I'm not gonna ever do that. And they'll do anything. Graduated extinction, on the other hand, is a lot of times what we'll employ. Why? Because of those parents coming in, they may not be able to do that because of that situation that occurred, the vomiting that occurred, the injury that occurred, and we'll just do more brief measures of extincting behavior. No evidence that one behavioral approach is better than the other, but that we tailor it to each individual. And we do a lot of education and prevention in the beginning. So if there is a child with illness, we'll say, if they are going to sleep in the bed with you, maybe we put a pillow between, so they're not, you're not having that sort of touch. Maybe there's just a distancing that we do. That's the kind of graduated extinction, or at least prevention, that we can do. And then we sort of say, I'm going to go get a cup of tea. I'll be right back to stay in bed, and then come right back so they know you're going to be back. And then you sort of make it longer and longer, and eventually they fall asleep on their own. You're teaching them that conditioning response is there. There's a lot of different ways you can do this, but those are some principles of extinction. I love this. This was written by kind of a little sassy writer here, the Cry Out Method for Adults. To figure out how to self-soothe, eventually all you know is what you do if you're miserable. And then there's the graduated extinction method. This is just funny. And I especially loved this bottom one. Just throw the whole recycling how it works. Pop the last of your melatonin gummies, which never work but taste great, and chunk that empty jar right into the trash. Now you go to sleep. But we don't want to overthink it. There's different methods, and they all work in some way. So does it work? Yes, it works. And I'm not going to go into this, but it works. And more importantly, parents want to know, am I damaging my child? And there was a study that came out, I should put it here. It says, does it damage your child? These children are fine. They don't have more propensity for anxiety disorder. So they go, oh my gosh, I'm hurting my child, right? But you're not hurting, you're teaching them how to sleep. And that behavior is modifiable.
Is there kind of like an age in like infants and toddlers at which, like, I know that you say before 6 months, you probably shouldn't, but beyond that, is it like too late sometimes to do that?
It's, it's not too late, but it is true that those conditioned response, they're harder when there's strong associations. And they say, when the child kind of 6 months, because we know that by 6 months, they're maybe sleeping through the night, they have all their ingredients. But even before that, you can start sort of at least some behavioral strategies to prevent conditioning responses. There's actually a small group of people, they're pediatricians, I think they're in New York, but they start right away with, don't let them ever be in your bed. And then there's a group of parents that are like, these are the cruelest pediatricians we've ever heard of. It's just horrible. There's a happy medium prevention strategies in the first 6 months. You have to have those strategies in place, Because you can't expect at 6 months to start training. They're getting used to whatever condition response. So if you're holding them to fall asleep, they will be held to fall asleep, to stay asleep. And so, and then, but as they grow up, the sooner we do it, the better. Because once they start crawling out of the crib and coming to your crib, that's harder, right?
I remember when we did it for my dog, she was close to 1 year old, and she was waking up multiple times during the night. She was very crappy towards the end of the day. But when we did it 4 days, of her crying, us crying.
Sure,
But
everybody.
then she started sleeping 30 hours.
Oh, good.
And she was, because I guess one of the big things is that they can learn to soothe themselves, so they sleep more.
Exactly, exactly, absolutely. There's some literature that says that sleeping is bad for both, right? Yeah, exactly. And we want to teach them that behavior. So it's hard, I know. 4 days is not bad. And I don't know if I have, do I have this? When does it go away? But you're right, it's within a week if you do it all the right way. The one thing you have to warn parents about is this thing called Extinction Burst, and I didn't put it on here. Extinction Burst is let's say, for example, you did that with your daughter, okay? 4 days in, she's not only crying, but now screaming and wailing, and it's the roughest night of your life. You're on call the next day. Your wife and you just like, I can't deal with this. What's going on? You know, we can go on and on about the stress level that would impact that night. Nobody gets sleep that night. Are you going to repeat it that next night? If you're exhausted, especially if, let's say, your spouse is saying, we're not going to do this again. No, I'm not going to do it. You know, you're not on board, right? And so what happens with behavioral extinction is that there could be an extinction burst, meaning that the behavior may start to maybe fade, and then all of a sudden it comes back and comes back with a vengeance. So it could be that crying episode that lasts all night long. And if you write it out and stick to your guns that next night, still not going to come in the room. You write out that extinction burst, it's more likely to be, to be successful. And then that week is over and you're done with the insomnia. But if you don't, and a lot of parents don't, they're like, something is wrong, and they think something is wrong with their child, and I don't blame them. Their screaming is a little bit different, their crying is a little bit different. Could something really be wrong? They go in the room, they rescue the child. So what did they just teach that child? That you scream louder and harder and longer, I will finally come in, and it just ingrains. Now that operant conditioning is stronger than ever. So you have to warn them about that extinction burst to say, it's gonna get ugly one night. And then they might actually come back, oh, that was a bad night, you know? And then you also want to make sure that everybody's ready for that, because if you're working the next day, you're non-functional, that'll impact you too, you know, your parents that are doing this too. So it's just sometimes you have to get your respite care all lined up. Ready to go.
Is there any literature for substituting, like, if it's caregiver interaction, the child requires to substitute that to a teddy bear?
Yeah.
Is that part of the?
That's called a transitional object. And yes, it is. So let's say, for example, I'm reading a book with my little 6-month-old who can't read, but that's a nice routine that I'm introducing. I introduce a little teddy bear with that routine. Their little hug on the teddy bear. They don't really care about the teddy bear, they care more about me at 6 months, but I'm putting that in as a part of that classic conditioning, right? Because now they go to sleep with this teddy bear, it's part of that routine. Every night, and then all of a sudden this teddy bear becomes the love of their life. They can't even go to the grocery store without it, but that's here or there.
Yeah, I'd love when you lose the face.
And when you lose the teddy bear, you lose sleep. And that's the problem, I guess, there. But the whole point of maybe a transitional object is it takes that conditioner away from the parents and introducing a different object that is more easily manipulated at night. If the teddy bear falls out of the crib, you have an issue. I have this wonderful video that I saw, you know, just this cute little video of, you know, I want my teddy bear, because it was out of the crib and they had to come back and it comes back out and went back in. But another question, that's actually a really important thing, is sometimes they don't have transitional objects, so we want to introduce that as we're trying to do that. The other thing is the question I had for you, crib, when do you take them out of the crib? Some parents may ask you this. So, you know, bassinet is a small little thing with babies in, and then the crib maybe for a while, rails are up. And then maybe top of bed or bed. When do you move out of the crib? Yeah, probably, probably with the child. A lot of parents, when they start to have sleep problems, maybe they don't even climb out. But they'll say, well, maybe they don't like their crib. The literature actually says that they sleep better and longer if they stay in their crib. That's just sort of the kids do better. And it could be that those are kids that are just better sleepers and they stay in their crib longer. My son stayed until he was embarrassing, like 4.5 or 5. He was a great sleeper. And my husband's like, I can't believe he's okay. Hey, Bob, don't fix it. And the literature supports that. Okay, so this is a slide that's really important because even though, and I said all those wonderful things about insomnia, even though we have to also be mindful that there could be some other comorbidity. And believe it or not, separation anxiety disorder exists in up to 10% maybe of children with insomnia. In order to be able to sleep on their own, they have to separate from their parent for that length of time. If they can't do that during the day, they're not going to do that at night. So we're going to screen for during the day, are they okay with you? But if they come in saying they're never away from me, never, like they're in the room like this, and they're never away from me for even a second. I go to get the garbage in the mail. This is true. You've heard this before. I go to the mailbox and my child is crying until I come back, or I can't get outside. That's a significant separation anxiety disorder, and there's no way that person's going to sleep. You can't actually deal with the insomnia unless you deal with separation anxiety first. So that's an important one. The other thing, of course, is kids in fear and anxiety at night, especially if they're scared and some other things. And so we want to be mindful that that could also be manipulative behavior. But if there's true fears at night, then we want to address that. And we want to be able to get them into the state of, I'm safe to be able to fall asleep. And it really depends on what they've been through. And so some of the things that it could just be bad news. children may have fears just for bad news. And we say, I don't want to watch the news in front of your children, all that good stuff. And then we can address co-sleeping because it's helpful to everybody to sleep. But we also want to be mindful that co-sleeping is more likely to occur in anxious children. We want to deal with that anxiety again before. So sometimes Carolyn Landis will be working with that child's anxiety before she deals with the sleep, because that's comorbid in that situation. So she's dealing with that situation. Okay. Now let's talk about this 2-year-old. 2-year-old is otherwise healthy, born at term, GERD on meds. He presents with sleep onset problems on some nights and both sleep onset and maintenance on other nights. So no concerns about separation anxiety. Just want to point that out. Does not always need parent to fall asleep. Sleeps better when the parent is with him. He often gets out of bed after lights out and asks for things, runs around, doesn't want to go to bed. Once asleep, he gets up and goes to parents' room about 2 times a week and takes an hour to return to sleep. The parents are tired. They tried melatonin, but it doesn't seem to help him stay asleep. The younger sibling was born when the problem started, but they are only getting worse. He's snoring, he's very restless at night with sheets off and off the bed. PSG with PLM index of 13 and OHI of 1.4. So what's your next step? Behavioral therapy, check iron studies, ENT consultation, all of the above. You could in a store. Oh, I'm sorry, I don't have the answer here. So the very first next step, I guess you will do some behavioral therapy and you're gonna do check iron studies. This is to illustrate one thing. He runs around and he doesn't want to go to bed. In a 2-year-old, insomnia, RLS can present like insomnia. This may seem like a limit setting type of situation. I don't want to go to bed, I don't want to go to bed, I'm running around and running around. It may present that way. The kicker here is that it's an intermittent thing. It's not a daily thing. He has problems with sleep maintenance. And so we did a sleep study. PSG shows PLM, so it's supportive criteria for RLS. And so we need to check those iron studies. So just remember PLM index of 5 or more. And I also wanted to point that out here. I did 13 for a reason, because you might think 15 is for adults, and that's abnormal, but for children it's 5 or more. So just be thinking about that. OHI, borderline, maybe primary mild sleep disorder breathing, but it could be waking him up. So I do agree that would be a very viable option. Maybe the very first initial next step is to address the PLNs. And then sleep maintenance insomnia would be associated with restlessness. We want to keep that in mind. And then if you haven't read this, I would put this in your kind of things to have, because it's for adults and children. But it's evidence-based consensus of the clinical guidelines for the iron treatments for restless legs. And this is the therapy for children. There's one like this for adults, but this ferritin level of 50 is considered the cutoff to treat. As you guys know very, very well, we do this all the time in sleep clinic, but it's 75 for adults. And then this is fine. We do, if it's low, we do iron therapy. And then if it's above 50, you may want to consider some other therapy. And then of course, IV iron, which I have not used in children yet. I've tried it in adults, but anyway, but it is, sort of potential for RLS treatment if they're not improving on oral iron therapy. Okay, this case was to illustrate what could look like a limit setting insomnia, and I meant to do that in another slide here, but it's RLS. And if they're coming to us, we have a very low threshold of doing this anyway. That's why I have a very low threshold. You guys know this. I do iron studies on sleep onset insomnia a lot because 2-year-olds can't tell us. I don't want to miss that RLS in that child. I'd much rather do iron than a sleep aid. And then of course behavioral therapy if things aren't improving, or at the same time. Okay, so now we have a 5-year-old, otherwise healthy, presenting with concerns about sleep quality. He's no problems going or staying asleep, just the quality. And why is that? Well, compared to his 4 other older and younger siblings, he moves a lot at night. He's not just his legs, he wakes up seemingly tired despite 11 hours of sleep. Mom sees him in the monitor, sees him fitful at night. He gets sleepy in car rides, he's irritable, especially after some worse nights. Dad worries about starting kindergarten, wonders if symptoms are related to the COVID illness they all had. No parasomnia, no RLS in the family, no snoring, 1+ tonsils, otherwise negative review systems. And the workup by the pediatrician is completely normal. His bedtime wake times are just almost picture perfect. What may be the etiology of his poor sleep quality? Could it be A, sleep disordered breathing or PLMD? This B, this long COVID situation that we're seeing, comorbid not yet diagnosis. Some insufficient sleep for his age, perhaps, because he's kind of sleeping during the day, or could he be a restless sleeper? Pretty basic. And it's weird that we're seeing some long COVID things, but I thought this would be a restless sleeper.
Yeah, it's like there's daytime symptoms.
Daytime symptoms, and this is a relatively new diagnosis. It used to be, it's getting, this restless sleep disorder is a very, very new diagnosis in children. It's very, very new. And it was thought that these children have just poor quality and insomnia agents didn't work and these kinds of things, but it sort of started to evolve into restless sleep disorder. And now it's an entity in itself. It's not an ICSD-3 because it's past that. It's sort of very, very new. And so what they saw was these very, very, very restless sleepers. So this child is very different than his other siblings. He's extremely restless and he's tired. He has some daytime consequence as a result. If he was restless, who cares? But he has this daytime consequence. And then if you age match and looking at true RLS and controls, these children do have issues with restless sleep. And they saw that they have decreased sleep efficiency similar to RLS, but not prolonged sleep latency like RLS, interestingly. And then they went on to say, okay, what other features might they have? And this was recently published, and this is why when we look at sleep studies together, we're looking at restless sleep disorder. We don't have identifiable ways to do this nicely yet. But we do see that compared to restless leg syndrome and restless sleep, and controls restless sleep disorder, patients with restless sleep have a lot of movements. And so what they found was their total movement index. It could be this, and any 5 movement is considered a movement. And they tallied them up, and they saw that 5 movements per hour or more, similar to PLM index, gave 100% accuracy with a restless sleeper clinically. And then there's other studies that show that ferritin is the same story. It's the same ferritin and iron stories we see with RLS. So there's similar pathways and mechanisms, but they're a restless sleep. So can you clinically diagnose restless without a PSG? Technically, no. And this is why. If you have a parent coming in and saying, they're so restless, something's wrong. Well, it can be inherited with ADHD, can't it? And in a report of children with ADHD who underwent a PSG, 81% reported restless sleep, but only 9% had restless sleep disorder. And so even if you have a complaint of restless sleep, we have to maybe say, we can start with iron studies if we don't want to get a PSG right away, but we want to consider a PSG to really look at sleep if we think that there's a true restless sleep disorder in that patient. But they could be restless sleepers in general. So we don't want to muddy the waters too much with this, but there's some criteria that are being developed for this disorder. Okay.
I can't remember the case we were supposed to write something. Oh, like we were gonna.
Oh, the parasomnia one.
Yeah.
If you're still interested, I have that somewhere. I think it is an important one to write up. Because it's been, parasomnia can be triggered by any kind of arousals. And can cause arousals, When we treated them, there was no more parasomnia. It's a wonderful case. I think it's a good, because this is a relatively new diagnosis, and it makes sense, we can make sense out of that case. That's true, you're reminding me. We should. Okay, moving on to adolescents, 15-year-old female with anxiety who can't fall asleep or stay asleep, hinders her from concentrating at school. Her Epworth is only 0, she's fatigued. She plays volleyball, she's a star student, top of her class, worries a lot if she has a game or test the next day. She's crystal clean, solid citizen, excellent sleep hygiene. She drinks a bunch of chamomile, does massage and progressive. I mean, she's a star, right? Her room is perfect. She lays in bed. She gets frustrated when she can't sleep. She estimates 3 to 4 hours of sleep with frequent awakening. That's not a lot, but her Epworth is 0. But do you think this is real? You have patients say, oh, yeah. And this is their perception. Worries and ruminates and thinking. So here's her bed and wake time. And, interestingly, she has some things that wake her up. So her circadian rhythm is okay. This is a real patient that I recently had. And, when you say, I'm going to find circadian rhythm, and it's like, nope, I wake up for this, and I wake up for that, and okay, well, she's in training. It's not circadian. And this is an interesting phenomenon. In her school days, she has a very difficult time going to sleep, but even on weekends, if she has a volleyball or something going on the next day, she can't sleep. What do you want to do as the next step? Prescribe worry time? Do you want to prescribe controlled release melatonin and tell her not to go to bed until 11? Tell her she is likely sleeping more than she realizes? Or CBT? Or all of the above? Or something else? What do you think?
We did A, I guess, for that patient.
You could, yeah. Very unfair question. I think that this is a great thing to do. Absolutely. And it is actually probably better because we can't do CBT in our clinics, so we do, but we can prescribe worry time. I did say CBT because that's always the right answer. But I agree with you. We would prescribe some worry time for her in clinic and then send her for CBT. C would be what? I'm sorry?
It would sort of ruin the relationship.
I agree. We used to call this sleep state misperception. You're not just getting 3 to 4 hours of sleep. No, come on, you're not even sleepy. That's impossible, right? So you're like, and what came out of this was, I'm going to go to the research here. The the perception of insomnia here, we call this now paradoxical insomnia. Because even though they might be sleeping, because this 3 to 4 hour sleeper, it is kind of hard to it is kind of hard to, it's already 10 o'clock. Okay, guys, so I'll end with this. There's more, there's a lot more, we just didn't get to it. I didn't know how much content. But just know that the paradoxical insomnia is, there was this thing that said, where in the brain is insomnia? If people are not perceiving it, then maybe we're not, because we would see it on a sleep study, and they say, oh, I didn't sleep at all on that sleep study. I'm sure you should tell me that. And they're like sleeping just fine. But we have superficial leads. We don't know what's happening on the perception level. And there are different, I won't go into this because you're not time, different resting networks that were looked at when we have somebody with paradoxical insomnia. They may not always have those resting networks, the communication between them that resting is to know that they are in fact sleeping. And it looks like cognitive behavioral therapy can reduce some of these default mode networks so that they can perceive sleep better. So at any rate, it helps with paradoxical insomnia. CBT does. That's it. We don't have time for this last one because this goes into a lot more complexity of medications. Perhaps we can do this at a sleep clinic if we have time. Maybe we can do that. This one, okay? We have to be mindful of your time today. I don't even think there was anyone here, but